So I'll first take off the orbital foreign body talk, and then subsequently I'll be discussing about orbital fractures. Now, well, I have no financial disclosures for this presentation, and full face photograph consent has been taken from all patients. Intraorbital foreign body are relatively rare, and it accounts for only 3 to 16% of ophthalmic trauma cases, mostly associated with penetrating injuries. It's important to remember that almost about 50% of the intraorbital foreign bodies are missed during the initial presentation. So we need to have a high degree of suspicion whenever we are dealing with the case of ocular trauma, and particularly in cases when there is persistent inflammation, when there is a sudden onset of vision loss or any onset of orbital complications, or when you find any parts of the foreign body in and around the globe, always suspect the injury with a foreign body. The clinical manifestations can vary from the clean-cut wound with a foreign body in the periorbital area, can also present as orbital abscess, a proptosis with exposure keratopathy, ptosis, persistent antisegment inflammation, or complete ptosis with lead, iron and copper, which cause intraocular complications, are rare to cause any orbital complication, and it has been proved in literature. However, if these foreign bodies cause an impending threat to vision or any vital structures, should be removed. CT scan plays an important role. So you can see here a foreign body in the supralateral orbit which is hyperdense and has got radiating patterns suggesting of a metallic scene, is very classical of a metallic foreign body. But at the same time, if you see this panel of photograph here, a hyperdense structure in the orbit, but it doesn't have a metallic scene, is could be a inorganic or a metallic foreign body. It could be an inorganic foreign body, and it could be something like a glass or a plastic. Now here you can see in this panel that if you have a hypodense lesion kind of thing in the CTs on the CT scan and traversing almost throughout the orbit, it could be because of an organic foreign body which is very fresh. Similarly, if you find here, if you a well circumscribed lesion here which is hypodense comparison in the periphery with a hypodense center, is also suggestive of an organic foreign body. Now here in this panel, if you see, there is a foreign body which is traversing in the infraorbit, causing a large floor fracture with prolapse of orbital contents into the sinus, is also can be detected on the sagittal cuts. So here in this panel, if you see the 3D reconstruction image, a hyperdense foreign body stuck into the supraorbital rim is gives us an important clue that a foreign body can also be there, and it can only be detected in the 3D reconstruction. So the importance of this slide is that whenever you order for a CT scan, it should be a complete panel, axial, coronal and 3D reconstruction images, that and all serial cuts has to be studied to get an idea of where the foreign body is. Now, as I've already discussed, in acute stage, a wooden foreign body will appear hypodense. In subacute stage, as it imbibes water, will become hyperdense. And in chronic stages, where it has imbibed more of water, becomes hyperdense, and that's how you find the hyperdensity of the wood here. Now, CT versus MRI. MRI is indicated only when you are confirmed that it is not a metallic foreign body. Otherwise, the first investigation is always CT. Now, in certain cases, when there is acute inflammation and you are unable to look for any a foreign body, and the history clearly suggests that it's a wooden foreign body, you can go ahead and do an MRI just to get an idea what and where the foreign body is. Now, surgical removal have got very fixed principles: minimal damage and maximal exposure of the foreign body. So, how do you enter the foreign body? It is preferably you should enter through the original site of trauma. That will cause minimal damage to the surrounding tissue. Meticulous and gentle exploration of the surrounding tissues and clear all the adhesions. No push at all. A gentle pull to overcome the resistance will usually take out the foreign body. We should also remember that if it is a wooden foreign body, it usually decomposes over time and shatters. So there may be very small components of that remaining within the orbit. So a thorough and copious irrigation with antibiotic saline is a must, and close follow-up is important to look for any complications arising out of it. Important here is to send all the foreign bodies for microbiological evaluation to look for the growth of organism and to change the antibiotics as per the sensitivity pattern. Now, with this I come to different case scenarios. So the first case is a 26-year-old male who sustained an injury with a wooden foreign body while he was gardening. He presented to us 10 hours after the injury. Left eye, the foreign body was fixed in the inferior medial orbit. The eyeball was pushed up, and it was any attempt on globe movement was causing severe pain. So the vision was just PL positive, what we could record on emergency. The right eye was absolutely normal. So this is what the CT scan showed. Now, in the axial cut, it shows that the foreign body appears to have penetrated the globe, whereas if you go to the coronal section, you can find the foreign body well correlating to the morphology of the wooden foreign body that you see in the external photographs. In the sagittal cuts, as I have already discussed, you can see a large floor fracture with the prolapse of orbital content. So in this condition, a transconjunctival approach was taken to remove the foreign body as well as repair the fracture with a poric seed, and this is what was the outcome. The vision recovered and the extraocular movements were full. Coming to a second scenario, it's again an externally visible foreign body here. It's a wooden foreign body with a hollow at the center. It is presented to us within 6 hours of injury because of a road traffic accident. The patient developed sudden loss of vision, and there was bleeding and pain from the site of injury. The patient had no PL in that eye. The right eye was absolutely normal. The left eye fundus showed vitreous hemorrhage and disc pallor. A B scan was done. The retina was attached. But what did the scan show? The scan showed a very clear hyperdense area in the inframedial orbit and a long hyperdense area right traversing the entire portion of the orbit and entering into the intracranial cavity. So it's a very threatening, life and sight threatening condition where the risk of meningitis prevails. So in this condition, we need an urgent removal, and with the help of a neurologist, a neurosurgeon, so this is what we could take out, an 8 millimeter foreign body from the brain through the orbital route. And following that, as per the antibiotic reports, proper antibiotics were given to prevent meningitis. So the outcome, the vision could not be salvaged, but we could save a precious life. So the importance is that externally visible wooden foreign body coming to you early with complications like intracranial penetration should be removed with the help of a neurosurgeon. A third case scenario is a foreign body which was hidden because of a trauma. The patient was treated initially, the wound was lacerated, then the patient developed a chronic discharging sinus, and the patient was referred to us for for the treatment of acute dacrocystitis, considering that it's a case of acute dacrocystitis, the patient was referred to us for DCR surgery. So on palpation, what we found was a nodular irregularity over the inferomedial part, and there was a draining sinus. So the vision was okay in this patient, the fundus was normal, and this is what, when you saw the CT scan, so you can see the scan here, a hyperdense area, because it was a 1-month-old injury with a small hypodense center here, and it was corroborating with that of the external, with the shape of a foreign body. And when we just entered through the entry wound, we could retrieve a large foreign body from the infraorbit, and the syringing was patent in this patient, and this is what is the outcome. So the importance is that just not go for that there is a foreign body, just do not go for imaging and rely on imaging finding. At least you have to put your, at least you have to palpate the orbit to find out any irregularity, and that may give you a clue to the diagnosis. And this is my last case where we have a hidden organic foreign body with delayed presentation. Patient is symptomatic. So 37-year-old male, contract laborer, had an iron injury almost 12 years ago to the left brow region. He was completely asymptomatic but developed intermittent pain over the left supromedial orbit on and off for the past 1 year, but it was more intense in the last 3 days. So vision was okay. There was, on palpation, we had we could palpate a small tender palpable nodule in the supromedial orbit. So the extraocular movements were full. So imaging showed a hyperdense foreign body here in the supromedial orbit, and you can see in the coronal cuts, it was very close to the supraorbital rim. So when we just did a lid crease incision and we found out that the foreign body was stuck to the superior orbit, it was a iron, it was a solid iron thing which is looking black, surrounded by dense fibrosis. So this is very important, that a foreign body, if it is inorganic, if it is metallic, it may cause symptom, and if it is symptomatic, and you have to remove to give symptomatic relief to the patient. So I have few other cases, but because of shortage of time, I will just skip these cases. So the last point which I want to reiterate is that just do not look for orbital foreign bodies, look into hi-fi things on a scan, but a simple cursory examination of the upper tarsal conjunctiva can reveal a large foreign body over there. And this patient had actually was treated almost about has visited almost about 3 or 4 consultants, and every time he was treated for acute conjunctivitis, and when it came to us, even I also missed the diagnosis and didn't care even to take a photograph, but this is what on eversion of the upper lid, you could find a large foreign body with a granuloma, and when it was removed, the conjunctivitis resolved. So the importance is that a high degree of suspicion is most important in such scenarios for better management of patients. Thank you.
Yeah, thank you, Samir. So you can move your next presentation. So is there any quick comment or question for Samir? Yeah, I think will be a short of time. We can take the questions at the end of